So today I just want to speak on breast cancer surgery. I think I see breast cancer patients all day long, basically, and I've been doing this for the last 5 to 6 years. And I think it's, from my perspective, it's great to give back to the community. Even though I do this every day in clinic, I just think it's, in the clinic setting, it can feel very intense and you may not always have your questions addressed. And so it may be good to kind of take this opportunity and chat with me. So I just want to introduce myself. I did my medical school training in Chicago at the University of Chicago. Then I did a general surgery residency in Dallas, where I was a general surgeon, and I did a breast surgical oncology fellowship at Cedars-Sinai Medical Center in LA. And then I went back to the University of Chicago as a breast surgeon. I was there for 4 years prior to moving to California, back to California and I was recruited by Stanford to come to East Bay to start build a breast surgery program from the bottom up in East Bay. I'm full-time in Emeryville, which is very close to San Francisco, actually. Stanford also has a facility in Pleasanton called Valley Care Hospital, and I'll be taking over that practice as well. So these are the topics I want to cover today. I want to go over the surgical options for taking care of the breast and how to, investigating the lymph nodes. I will be going over the reconstructive options briefly, and I also just want to talk about some of the post-surgical issues, including survivorship issues. Many of you probably know the statistics. Breast cancer is the most common cancer in women in the United States and in the world as well. And breast cancer trails lung cancer as the second leading cause of cancer-related death in women in the United States. But despite that scary number, if you look at the survival trends of breast cancer over time, we can see this upward trend and improvement in survival in breast cancer over time. In fact, today, it will be here. Oh, sorry, going back. Breast cancer survival is over 90% at 5 years. So what does that mean? That means at 5 years after diagnosis for all comers, 90% of the women diagnosed with breast cancer will be alive. That's actually a really good number. And for women with localized breast cancer, that number is even better, approaching 99% at 5 years. And if you look back, in the 1970s, survival is about 70%, but you go back even further to the early 1900s, survival in breast cancer is very low, 40%, despite us doing major surgeries. So why is that? So it really, first of all, this improvement in survival is somewhat attributable to starting mammography screening in the early 1990s and late 1980s. But really more recently, we're doing a lot of what we call multimodality therapy. So that includes surgery, radiation, chemotherapy, and hormone therapy. And we know that surgery alone does not treat or cure a breast cancer. We really need all the other modalities to minimize the risk of recurrence and to improve survival. And also recently, really, in the last 10, 20 years, a lot of emphasis has been placed on how do we do less surgery? How do we pick the right patients to do less chemotherapy? And how do we do less radiation? Because we know everything we do has side effects. So how do we do less invasive therapy without compromising the overall outcome. And a lot of emphasis is placed on maintaining or improving quality of life after cancer treatment. So I'm going to start with surgical options for the breast and for the axilla. So many of you may have had breast cancer surgery, lumpectomies or mastectomies and lymph node surgery. So usually I approach the breast and the lymph nodes as two separate entities. So one of the first questions I get from patients is how to decide between a lumpectomy and a mastectomy. For most patients, a lumpectomy is essentially equivalent to a mastectomy in terms of the overall outcome. So one is not necessarily better than the other, and really have to pick, look at the individual case. If the tumor is small and the breast is relatively large, then a lumpectomy makes sense. But if it's a larger tumor in a small breast, then we may have to do a mastectomy. And here I've listed some of the pros and cons associated with each procedure. We know that with lumpectomies, it's a shorter surgery, fewer complications, faster recovery, and the contour of the breast is maintained. You still have that breast, still have the sensation. But the flip side is that you would need radiation for the most part after a lumpectomy. And because you still have the breast, you will need to have future mammograms. Now, a mastectomy is a longer surgery. And if the patient chooses to have reconstruction, then the procedure could take even longer. And then we know the recovery time for a mastectomy is longer than for a lumpectomy. And there could be more surgical complications and longer healing time. And there is always that loss of sensation. Even if the patient gets reconstruction, the sensation in the skin, the sensation in the nipple can be very different. And no matter how good a reconstruction, the contour is always going to be just a little different from how things were before. But the flip side is that usually after mastectomy, there's no need for radiation unless there is involvement or there's cancer in the lymph nodes, or if the cancer is very large in the breast. And usually there's no routine mammograms needed after a mastectomy, even after reconstruction. And I want to touch upon recurrence because a lot of my patients tell me, oh, I don't want to think about a recurrence. I don't want to have to deal with this ever again. And so maybe that's why I should pick a mastectomy over a lumpectomy. So recurrence can actually still happen with a mastectomy because there's still a little bit of that residual tissue under the skin. And recurrence can happen in the lymph nodes. Recurrence can happen elsewhere in the body, even after mastectomy. And it really depends on the particular cancer. After a lumpectomy with radiation, the local recurrence rate is actually relatively low. Usually I quote about 1% per year. And that number is further reduced by hormone therapy and or chemotherapy. And that's why the systemic therapy and the hormone therapy and the chemotherapy are very important in terms of preventing a recurrence happening from elsewhere in the body. And also we just want to talk about contralateral prophylactic mastectomy, which is removing the healthy breast, removing the other breast. This is a topic that comes up very frequently too, because women don't want to ever go through this anxiety and the stress that's associated with cancer treatment. They just don't want to deal with this ever again. It's a discussion I have rather frequently with a lot of my patients. I usually tell them that there is actually no scientifically proven benefit to removing the healthy breast. The risk of having a new cancer in the other breast is actually much lower than perceived. That risk is about 0.5% per year or less. So if you're 60 years old, the risk of having a new cancer in the other breast at the age of 80 is really only about less than 10%, which is a very low number. And there is no survival benefits. It doesn't make you live any longer by removing the healthy breast, because it's the cancer that you have now that will dictate the prognosis and how long you have to live. And by doing more surgery, there can be more complications and more recovery time. But I recognize that, and everyone does too, that there's this peace of mind issue that comes with removing the healthy breast, right? So usually if the patient understands the benefits and risks that go into removing the healthy breast, and they feel like they just need to have that procedure to get that peace of mind, all of us in the breast surgeons, I will be happy to do the procedure. Now I want to talk about aesthetics after lumpectomy or mastectomy. Usually after lumpectomy, aesthetics is relatively good, even if no additional work is done, because a lumpectomy usually is not removing a lot of breast tissue. But patients may still have some dimpling or indentation or flattening where the lumpectomy is done. And that happens because after a lumpectomy, there is this empty pocket, a seroma cavity. And over time, the seroma cavity shrinks, and then you get radiation, and that really makes the seroma cavity shrink, and that kind of pulls the skin inwards, and that's where how the indentation happens. So to avoid that type of dimpling in the skin, it's important to eliminate or minimize that empty pocket after lumpectomy. So one of the basic things that a breast surgeon can do, that I do, is to rearrange the breast tissue, or kind of bring the breast tissue together to eliminate that empty pocket after lumpectomy. So without that empty pocket, even with radiation, the dimpling or the indentation is pretty minimal after radiation. Now, there are some more extreme cases that I would do with the plastic surgeon if the tissue rearrangement is more drastic. So in this particular patient, we did a lumpectomy in the left breast where the cancer is, and then the plastic surgeon did what they call an oncoplastic reconstruction, basically rearranging the tissue on the cancer side and doing a breast lift at the same time. And for symmetry, the plastic surgeon did a breast reduction and a lift at the same time, and this is the end result. Additionally, there is this device called BioZorb that breast surgeons sometimes use. This is a device that is placed into the lumpectomy cavity. It's kind of this coily shaped thing that comes in different shapes and sizes. The plastic part dissolves over time, over the span of a year, and there are these 4 titanium markers that are left in place in the breast that kind of mark the tumor, or where the tumor was. This device was originally meant really more for the radiation oncologist, so they could see where the tumor was and to better target the radiation beams. But over time, breast surgeons have really come to like this device because we find that it kind of helps maintain that contour, and especially in smaller chested women who don't necessarily have a lot of tissue that we can move around. Now, after a mastectomy, there are different options for reconstruction as well. And it's really the advancement in reconstructive techniques that kind of pushed the breast surgeons to do these advanced mastectomy techniques. So many of you are probably aware of the skin and or nipple sparing mastectomies. So in the top row, the patient had a cancer in the right breast, pretty close to the nipple, which is why we had to remove her nipple with the mastectomy. So essentially, she had a skin sparing mastectomy. She also had a contralateral mastectomy, and we were able to save her nipple. And we made an incision to the side of the breast, and we saved her nipple. Then she had an implant-based reconstruction. And on the bottom, she had bilateral nipple-sparing mastectomy, and the incisions were placed in that inframammary fold, so under the breast fold. So this is a very aesthetically pleasing procedure. Nipple-sparing mastectomies are not for everybody. We have to pick the right patient, the right case. Now, if there's cancer right under the nipple or very close to the nipple, then we usually don't want to save the nipple because we may be leaving behind cancer cells. Or if the patient has very large breasts and the nipple positions are not at optimal, so if the breasts hang a lot, then that's not an optimal patient either. Now, breast reconstruction, there's kind of two broad categories of breast reconstruction. There is the implant-based method, and there's autologous reconstruction. So with an implant, many of you are probably familiar, this is the most commonly used reconstructive technique after mastectomy. And it usually starts with a tissue expander, which is a temporary implant. And the tissue expander is placed under the mastectomy skin, sometimes directly under, sometimes under the muscle. And the tissue expander gets expanded in clinic over time to the desired fullness, and that is then swapped out later for the permanent implant. Another way to reconstruct the breast is using one's own tissue, and that method is called autologous reconstruction. And that tissue usually comes from the abdominal fat, kind of in the abdominal wall. So the patient essentially gets a tummy tuck at the same time. And the flap is called DIEP flap, which is the name of this of the flap procedure. And the abdominal wall tissue or the fat gets placed into the this empty pocket created after the mastectomy. And we can use one side or both sides, just depending on the volume that we want to achieve. Then there are pros and cons with each of these procedures. With an implant-based method, it's a faster procedure, less recovery, but it is a foreign body. And some patients don't like the idea of having a foreign body in their bodies. And if there's an infection, sometimes, not often, we may need to remove the implant if we cannot treat the infection with antibiotics. Now, for autologous tissue that's much more resistant to infection, very rarely do we need to remove it. Actually, we never really have to remove the flap to treat an infection. We just treat it with antibiotics. And the shape overall is very good. It's more kind of natural looking. And it's a very kind of durable long-term reconstruction, but it's a much longer procedure, and it does require special expertise. So at Stanford, we have microscopically trained plastic surgeons who perform this procedure. In the community, there are plastic surgeons who do these procedures as well, but you obviously want to go to a center that does a lot of these procedures if that's what you want to have done. At Stanford, we recently have come up with a new technique for reconstruction, because we see many women who have smaller breasts and who don't have enough tissue from the abdomen to make to make a breast, but they also don't want to have implants, then they're left with not very many options. So the plastic surgeon at Stanford has come up with this technique called Omentum-based reconstruction. So the omentum is this layer of abdominal fat that covers the internal organs. If we remove part of it, or even all of it, there's really no kind of long-term clinical consequences. Kind of like the appendix, take it out, it's, you don't really feel any different. So the plastic surgeon uses a cellular dermal matrix, or ADM, which is kind of like a dead cadaver tissue. So it's a biologic mesh, essentially. They use this mesh to create a pocket and fill it with the fat, the omental fat. And this whole thing then gets placed into the mastectomy pocket as a reconstruction. So there is no foreign body. It's all kind of your own tissue. And so far we've had very good, results. Another technique that you might have heard about is called sensation preserving mastectomy. So as I said earlier, when you have a mastectomy, no matter what kind of reconstruction is done, there's always going to be some degree of sensation loss. Even if we save the nipple, the sensation in the nipple can be very, very different, or it can be insensate in many cases. And the sensation may never come back, or come back very, very slowly. And some women really want to preserve that sensation as much as possible. So if you look at the sensation to the skin and to the nipple, it really comes from these nerves that come out from next to the sternum, or the breastplate, or from the side of the rib cage. So when the breast surgeon is doing the mastectomy, we can try to save some of these nerves that come out from the side of the rib cage. And the plastic surgeon then attaches the cut end of the nerve to the base of the nipple to try to preserve the sensation. And if there's a gap, if the nerve end doesn't reach the base of the nipple, the plastic surgeon will use a nerve graft as a bridge to connect the nerve to the end of the nipple. It is a procedure that requires special expertise, and it's done at Stanford by the microscopically trained plastic surgeons. The operating time is much longer, and we have to pick the right patient for it. Usually, patients who have relatively smaller breasts would be more ideal candidates. And if patient really wants to have the procedure, then that's something that we offer, but we don't routinely offer it just because it's it takes a longer time to do. And certainly if there's cancer, right here, then we know that we can't save, the entire length of the nerve. Now I just want to shift gears and talk about lymph node surgery real quick. So as we know, a lot of the breast drainage goes into the lymph nodes in the armpit. And many of you probably have had surgery and might have had either a sentinel lymph node biopsy or an axillary dissection, but some form of lymph node removal at the time of the breast surgery. So why do we want to remove these lymph nodes when we're doing cancer surgery? So one is important for cancer staging. So if you have one lymph node or no lymph nodal involvement versus 10 lymph nodes, the prognosis can be very different. So it's important for us to know what the stage of the cancer is. And also the extent of the disease in the lymph node will also help us kind of guide the adjuvant treatment, so guide the decisions regarding chemotherapy and for radiation as well. So there is the sentinel node biopsy, which is removing just a handful of lymph nodes, 1 or 2 or 3 lymph nodes at the most from the armpit. And that is the much more common procedure these days. And every once in a while, we will still need to do an axillary dissection, which is removing most of the lymph nodes from the lower armpit. We don't do the axillary dissection as much anymore these days because we know there there are other ways to treat disease in the lymph nodes, and surgery is not the only way. But there every once in a while, we may still need to do that procedure. So lymphedema is something that many patients are concerned about, and that is accumulation of this extra fluid in the armpit, usually as a result of the disruption in the lymphatics in the armpit. And so here I listed the lymphedema risk rates associated with these various procedures. So with a sentinel lymph node biopsy, the risk of lymphedema is very low, less than 5%. So it's a very safe procedure to undergo. With an axillary dissection, the lymphedema risk is about 15 to 20%, which is not surprising. So the more lymph nodes we remove, the higher the risk of lymphedema is. With nodal radiation, the risk of lymphedema is about 10 to 15%. So this is radiation to the lymph nodes, not just whole breast radiation that is done after a lumpectomy. This is kind of more specialized radiation where the radiation beams target the armpit and sometimes above and below the collarbone and even next to the breastplate. And when you combine axillary dissection and nodal radiation, the risk of lymphedema can be much higher, as high as 40%. So how do we reduce the risk of lymphedema? And this is something that surgeons and radiation oncologists are well aware of, and we are constantly trying to, thinking of ways to reduce that risk because, it can be a very, big problem. Once lymphedema develops, it's hard to go back. So the best way of treating it is to prevent it from happening in the first place. So first of all, we just need to do less, right? We need to do less surgery, less radiation, but safely. And that's why we kind of slowly went away from doing axillary dissections on everybody. We're doing more and more sentinel lymph node biopsies, and we're doing more nodal radiation, and instead of removing those lymph nodes with surgery. It's also important to have the patient be evaluated by physical therapy, and this concept of prehabilitation is just as important as seeing a physical therapist after the fact. So if I know I'm I'm doing an axillary dissection on a patient and the patient is at high risk for lymphedema, I send the patient to see a physical therapist, a lymphedema specialist before the procedure. And there's something that the surgeons do that I do when I'm doing an axillary dissection to try to minimize the risk. And that procedure is called axillary reverse mapping, or ARM. So the idea of ARM is to identify the lymph nodes in the armpit that drain that arm, that hand. So we do it by injecting some dyes into the upper arm, and the dyes go backwards into the armpit. And the lymph nodes that pick up that blue dye theoretically would then drain the arm. So when I'm doing that procedure in the axilla, I look for that blue nodes and blue dye, and I try to save those lymph nodes if I can. Now, every once in a while, this blue node is kind of in my field of dissection or is clearly involved by cancer and needs to be removed. But if I see the lymph node, I try to save it, and I think that does minimize or hopefully reduce the risk of lymphedema. And there's also a procedure called Lymph, which is basically it stands for kind of this micro anastomotic connection, to kind of reestablishing the connection between the lymphatics and the veins, done kind of under by the plastic surgeon under the microscope. And the idea is kind of similar. The plastic surgeon injects some kind of dye into the upper arm, and the dye goes back into the armpit and identifies, and we can see the lymphatics that drain the arm. And the plastic surgeon then connects the lymphatic vessel to the veins in the armpit and to kind of reestablish that connection. again, to hopefully reduce the risk of lymphedema. And lastly, I emphasize the importance of weight loss to my patients. We know that obesity and overweight is a big risk factor for developing lymphedema. Now we hear about, not doing blood pressure or not taking blood draws on that arm. And if you can avoid those things, great. But really, recent studies have not shown those things to be a big risk factor. So, if you need to have the blood pressure measured or have blood draw on that arm, that's really okay. And if you take a long flight, that should be fine too. But weight loss obesity has been shown consistently to be a major risk factor for lymphedema. And I also want to touch upon post-mastectomy pain syndrome. After mastectomy, it's actually not uncommon to have, pain and this tingling sensation in the chest wall. And every once in a while, that pain can become chronic. And this pain syndrome is really more of a neuropathic pain. It comes about as a result of nerve injury during surgery or radiation, and chemotherapy can cause nerve injury too, and can cause kind of tingling in the fingers and toes. And it can present as this tingling sensation or burning sensation or numbness in the chest or in the armpit or even on the upper arm. And the first thing to do is to tell your doctor about it. And the first thing for me and for the cancer providers to do is to make sure there's not a local recurrence and that there is not an infection that needs to be treated. And those things can be ruled out pretty quickly from a physical exam. But once those things are ruled out, how do we manage those pain symptoms? Again, the best way to manage it is to prevent it from happening in the first place. So again, it goes back to doing less treatment safely. So if I can do a lumpectomy, that's what I would recommend over a mastectomy. And if the patient can avoid an axillary dissection, then I will opt for a smaller lymph node surgery or just offer irradiation to the lymph nodes instead. It's also important to maximize pain control after surgery. Some studies have shown that patients who had uncontrolled pain after surgery might be at higher risk for developing post-mastectomy pain syndrome. It's also important to exercise and see a physical therapist to kind of improve the range of motion in the chest wall and in the arms, and those exercises can definitely be helpful. And psychological therapies, relaxation, mindful-based exercises can be helpful as well. Usually narcotic pain medications are not helpful in dealing with this type of neuropathic pain, and we need gabapentin or some type of neuropathic pain medication to manage the pain symptoms. And in more severe cases, we send the patient to the pain service or to see the physical medicine and rehabilitation services to get treated, and they may be able to do nerve injections or pain injections or something like that. Lastly, I just want to talk about survivorship, and it's a big component of cancer treatment and cancer management these days. And survivorship really refers to this entire journey of being diagnosed with cancer, going through treatment, and then living your life beyond cancer treatment. You saw earlier that I mentioned that breast cancer patients can live a long life these days. And so how do we make sure and how do we help them live a long and fulfilling life with a good quality of life? And survivorship has many components. It's not just cancer surveillance, but it's also dealing with the side effects from the treatments and the medications, cardiac issues, fertility issues, genetics, sexual dysfunction, etc. So cancer surveillance after cancer treatment. Usually we recommend a clinical exam 1 to 4 times a year for the first 5 years and then annually thereafter. So usually between seeing the surgeon, the medical oncologist, and maybe the radiation oncologist, you get at least 1 or 2 physical exams a year. And for those women who had a lumpectomy or still have an intact healthy breast on the other side, you need an annual mammogram. After a mastectomy, even with reconstruction, there is no need for routine breast imaging. So you don't need to get an annual mammogram or MRIs or anything like that, provided that the mastectomy is done well. And I do have to say, not all mastectomies are done equally. I've certainly seen my fair share of patients coming from, who were treated elsewhere and who had a mastectomy supposedly, but you do your exam where you look at their imaging, you realize how much, that breast tissue is left, and you're like, oh, that's really not a mastectomy, but basically you had a large lumpectomy. So, so it's especially after nipple-sparing mastectomy, because it's a difficult procedure to do, and people worry about how the skin or the nipple are going to look after. Some surgeons tend to leave more tissue under the skin or the nipple, but then we know that if we leave a lot of tissue behind, then that may be at risk for developing a recurrence, especially if we're not following it with imaging. And also there's no routine labs or imaging screening needed to detect metastases, so to look for disease developing elsewhere. Lifestyle issues, these are pretty much common sense issues. I ask my patients to, try to stay as active as possible. I realize it's not easy during COVID, and I know I'm not getting this 20 minutes a day of exercise, but do your best. So if you can squeeze in at least 20 minutes of moderate activity per day, that's probably for the best. And moderate activity would be something that that makes you breathy, but you can still talk when you're performing the activity, but not necessarily sing a song. I ask my patients to try to maintain a healthy body weight, eat a healthy diet, limiting alcohol intake to no more than 1 drink per day. And if the patient smokes, I ask her or him to stop smoking. So these are kind of what I think to be kind of relatively kind of common sense things. I don't think there's anything magical to this. It's not easy to do, certainly. It's not easy to always eat a healthy diet and exercise. I realize that, but just do your best. And if you crave a piece of chocolate, then it's totally fine. Eat a piece of chocolate, but maybe don't just go overboard. Lastly, I want to talk about hormone-related symptoms. So a lot of you may have taken or maybe on tamoxifen or anastrozole or similar medications for hormone blockade if you had a hormone-positive breast cancer. And we know that there are side effects associated with these pills. The most common ones are hot flashes, mood disturbances, kind of the menopausal symptoms. You can have vaginal dryness, sexual dysfunction, and with anastrozole, there's the potentially arthralgia and achiness, and the risk of osteoporosis. And it's not easy to stay on these pills for at least 5 years, which is the recommended amount of time after cancer surgery. And if you do have those symptoms, it's really important to talk to your provider about it. And I have some patients who just stop taking the medicine when they have these symptoms, and I understand these pills are not easy to take, but they only work if we take them, right? And so, and we can't help the patient deal with the symptoms if we don't know about them. And there are ways to manage the symptoms. We can always just stop the pill, take a pill holiday, and then resume maybe a month later. And usually even by doing that, the symptoms may lessen the next time you start it. And there are medications that we can prescribe for hot flashes. Low dose antidepressants are very effective in treating hot flashes. Acupuncture, exercise, yoga, Pilates can also be helpful with regards to arthralgia and hot flashes. And with regards to kind of the vaginal and sexual issues, using a vaginal moisturizer and lubricant can be really helpful. Vaginal estrogen is still kind of controversial. I think it's something that can be discussed if all else fails. It's not my, first line treatment for vaginal dryness, but if you've tried everything else and this, the dryness is just a big problem, then it's something that we can discuss. So this is the end of my talk, and I'm sure a lot of you have questions. This is where I'm located in Emeryville. And in Emeryville, it's a clinic building with an outpatient surgery center. We have breast imaging, mammogram, ultrasound, breast MRI, and we can soon do breast biopsies. I can do a lot of my surgeries, outpatient surgeries, especially in Emeryville. And at Valley Care in Pleasanton, it's a standalone hospital. There's all the breast imaging services, and I can do outpatient, inpatient cases there as well. And this is my contact information. So this concludes my talk. I will stop sharing my screen, and we can, I'll be happy to answer any questions that you may have.
That was wonderful. Thank you so much, Dr. Bao. And now I will also spotlight Erica so that she can ask the questions that have come in.
All right. Thank you so much for that wonderfully informative talk. I really appreciated the updates on new surgical techniques, some of which that I had never heard about before. Thank you. At this point, we have just a couple of questions, several of which are actually probably more appropriate for a plastic surgeon, but since you did talk about plastic surgery, I'll throw them at you. So one question is, how often should an implant be replaced?
So some people say every 10 years. I think that's a common answer is every 10 years. Although if you don't have any issues with the implant and you don't feel any abnormalities and they look normal, they feel normal, there's really no reason to replace them every 10 years.
Okay. And then I know you mentioned that surveillance with mammography is not necessary after a mastectomy, even with reconstruction. But how about just the surveillance and frequency of that, checking the implants for things like rupture?
So after a mastectomy, so when we're checking for cancer recurrence, that's what the surveillance would be for. It's really all by clinical exam, just because after the mastectomy, there's only a very small amount of, or there should be just a very small amount of tissue under the skin, and then the implant is right under that, or maybe the chest wall muscle is under the skin, and then the implant. So by doing a physical, by just palpating and feeling, we should be able to feel any small masses that come up. And so if you feel a mass, then it's important that you tell your provider that there's something going on, and then we can do, I'd start with an ultrasound or maybe an MRI or something. Now, in terms of checking for implant rupture, it's not something that we usually will monitor with any imaging with. Now, it's something that I think you will notice. Usually when there's an implant rupture, probably might come with trauma, or you will notice a deformity in the contour. Like the breast will just look different because there's no breast tissue left. Now all you're looking at is the contour of the implant. So I think it will be very noticeable when you have an implant rupture. Or if you have any worries about it, see the plastic surgeon about it and they can do an evaluation. But it's not something that we will usually kind of do imaging for, because it doesn't happen that often, and you will know when it happens.
Okay, great. Thank you for that. And then another plastic surgery question was someone that had a DIEP flap that failed and then had a latissimus dorsi flap, and they're currently doing great with it, but wondering if there are any potential long-term side effects that might creep up.
So in terms of, cancer surveillance, I mean, it should be fine. Keep seeing the cancer, surgeon, and they will do the physical exam. But in terms of kind of the long-term consequence of using the latissimus dorsi muscle, which comes from the back, I don't know, when they did the procedure, if they took, muscle or how much muscle. Sometimes they may just take a sliver, but mostly just the fat above the muscle. So if minimal muscle is taken, then that really shouldn't affect the motor function, but if they take a lot of muscle, which you may just have a little trouble doing pull-ups, but it should not affect the daily movements. But I think if you're an athlete and who that may be something to bring up with your plastic surgeon.
Okay, great. Thank you. We have a question about, what if you're large-breasted? Is there any way to maintain your size without a reduction on the other side?
So usually, after, I guess, so just trying to understand the question a little bit better. So usually after a lumpectomy, with a lumpectomy, we are reducing, the breast volume, because we're removing the, part of the breast tissue. So that breast will always be smaller than the original size. And to make it bigger, you would have to probably use an implant. But usually, we, after lumpectomy with reconstruction, the breast is always smaller. And usually those procedures are for larger women who kind of want to have smaller breasts. Is there any way to maintain the size without a reduction on the other side? I think usually, I think either with an implant or kind of moving your own tissue around to kind of to replace that tissue that's removed with a lumpectomy. But that kind of gets to be a relatively a big procedure. So something to discuss with a plastic surgeon.
Okay. And if you are an athlete, for instance, a swimmer, do you find that people are able to keep up that type of activity after a mastectomy?
Yes, since we are when we do a mastectomy, we're not removing any chest wall muscle. But after mastectomy, no matter the type of reconstruction or no reconstruction, there's always going to be some degree of chest wall tightness. So it's important to see a physical therapist if you have that range of motion or chest wall tightness, to kind of expand your chest wall, and depending on the reconstruction, now if you are having an implant-based reconstruction and they end up putting the expander or the implant under the muscle, then they're kind of stretching out the muscle. Now that really shouldn't affect swimming, but again, if you're just an big athlete, then some plastic surgeons may choose to just put the implant above the muscle. So then, you're not having to deal with kind of stretching out that pec muscle to cover the implant. Any kind of stretching to the muscle may cause, some degree of trauma.
Okay, great. If someone had a diagnosis that was treated with a lumpectomy and radiation, and then they experienced a recurrence, is mastectomy the only option?
Very good question. I guess the standard answer is yes, but actually not really anymore. So it really depends on the case and depends on now how far out you are from the previous, the lumpectomy and radiation, and how big this recurrence is. So, and the reason we say, mastectomy may be the only salvage option is because we don't want to have to re-irradiate the breast. So if you have another lumpectomy, then we have to do another round of radiation, and then two rounds of radiation can just be a lot of toxicity and may cause a lot of fibrosis to the breast. But if you are a few years out from the previous treatment and this recurrence is small, now say less than a third of the breast, then we can consider doing another lumpectomy and just treat you with what we call partial breast irradiation after surgery. So instead of radiating the entire breast, like the first time, then we just kind of radiate the area where the tumor, this recurrence is, and the area just immediately surrounding the recurrence.
Okay.
So that's an option for some patients, but not all.
Okay, that's great to know that there's that option. Someone would like to know about a newish type of reconstruction that was under development when they were diagnosed 10 years ago with growing fat cells in a petri dish to use in reconstruction. Do you know if that's something that's still being explored?
I have heard of that. Actually don't really know much about it, I have to say. I imagine that would take quite some time to do, so may not be an option for women who really need to have surgery in the next few months and who want to have reconstruction at the same time. So I'm not very familiar with that technology. And I know in my experience, it's not something that we come across very frequently.
Okay, thanks. For someone that's about to start chemotherapy, who had a lumpectomy, which after chemo will be followed by radiation and an aromatase inhibitor, should they consult with a physical therapist specializing in lymphedema for preventative techniques?
Personally, I think there's never any downsides to seeing a physical therapist early on, even if you're low risk. I think they can do some magical work. They can, even if you don't have seroma or are low risk for developing lymphedema, then they can help you with that range of motion. Because during radiation, your arm is like this, and you're getting treated every day, and you may just have some degree of the shoulder dysfunction or range of motion issue with their shoulder, and it's always helpful to have somebody look at you before and after. No, not all insurance would cover that kind of treatment, so you have to kind of check with your insurance. But I think if you can see a physical therapist, there's never a downside.
I agree. We have a question about dealing with the lymph nodes. I'm not sure I fully understand the question, but I'll read it to you and see what you think. So is there an effective way of removing a limited number of lymph nodes after a sentinel lymph node so that an axillary lymph node dissection can be avoided? So
really, yeah, I'm just thinking, well, after a sentinel lymph node biopsy, I think the reason to go back and do more surgery in the axilla after a sentinel node biopsy would be, if you would be to do an axillary dissection. That would usually be the goal. So talk with your surgeon and to see kind of what the intent of the procedure is. And I imagine that they would be doing an axillary dissection. And so maybe this patient is asking, how to do less surgery, right? I think, check with the surgeon, see if they do this procedure called ARM, right? It's a very easy thing to do in the operating room. I do it for all of my patients who I do an axillary dissection on. Kind of learn about their their techniques. When we're kind of taking out the lymph nodes during an after dissection, there are different anatomical borders that we follow, but we don't try to strip everything off of those borders. We try to save some fat. So there's some of that to it too, which would be kind of hard for the patient, I think, to understand beforehand. But see a physical therapist, see a lymphedema specialist before surgery, and see the same person after, and just follow with a lymphedema specialist. I think it's probably the best thing to do. And if the patient's overweight, work on losing weight.
Okay, great.
Can I just jump in really quickly? I know we're getting close to 1 o'clock and we still have a few more questions. Is it all right if we keep going for a few minutes, Dr. Bao?
Yeah, it's fine.
Okay, thank you.
Okay. Can you touch on how all of these surgical techniques and the healing process after them impact the future monitoring of breast cancer?
Yes. So I think what this patient is getting at is, when we're doing less, how do we know that the cancer is not recurring, like in the armpit, if we're doing less surgery, right? So that's why we do randomized control trials. We don't just one day say, okay, we're just going to do less surgery, we're going to do less radiation. Everything's well studied before we kind of embark on these kind of de-escalation of treatment. So when we went from sentinel node biopsy to when we went from after dissection to sentinel node biopsies, we had multiple clinical trials, and when we had de-escalation of removing cancerous lymph nodes, we had multiple clinical trials showing that it's safe to do so. And now, as a surgeon, every once in a while, I may do less without all the clinical evidence being there, and I always disclose that to the patient, and we discuss the pros and cons. Like for example, if we're kind of on the fence about if we should go take more lymph nodes or not, or if we should do XYZ, and I really try to lay out, the benefits and risks, and yes, especially if there's no clinically, proven data showing, one is superior than the other, so we kind of make this decision together. And a lot of times there is no right or wrong answer. But in terms of surveillance, right? So, clinical exam, mammograms, with the armpit, we don't routinely, do ultrasound of the armpit or MRI to look out for the armpits, really clinical exam, because we know actually, in fact, it's interesting that recurrence in the armpit is not as high as you would think, even when we leave cancerous lymph nodes behind. For some reason, we just don't see a lot of, even if there may be cancer left in the armpit, it doesn't always pop up in the future. It may just go away with radiation. It may go away with hormone therapy or chemotherapy, or may never become clinically evident or clinically meaningful. So it's not something that we kind of routinely, monitor with imaging, but we do, do a good physical exam a few times a year to make sure.
Great, thank you. And then the last question is someone who has had bilateral breast cancer diagnoses at different times, my understanding. They have had mastectomies as treatment, and then an expander placed, which it sounds like has been in there for quite some time, 2.5 years, if I'm reading it correctly. And they're now thinking about going flat, but are concerned about the length of the surgery and the anesthesia and what effect that might have on cognition, because they're already experiencing some cognitive decline. Do you have any comment on the effect of surgery on cognition?
The effect of surgery on cognition. I have to say I don't know too much about that, because I don't think there's a really necessarily direct relationship between surgery itself and cognitive effects. I mean, like, under general anesthesia, you're getting the medications and maybe you may feel, certain side effects from the anesthesia, but that usually does not linger for a long period of time. A lot of the cognitive side effects that, that we see from cancer treatment usually are associated with, undergoing chemotherapy, or just the general, stress that comes with undergoing this journey. But surgery itself is usually, I like to think it's not directly associated with any cognitive, side effects. But to go from, tissue expander to just being flat, if you've already had a mastectomy, it's actually not too big of a procedure, since really the procedure is done. We're just removing the excess skin, right? But a question I would want the patient to consider is, why, you could easily maybe just go from a tissue expander to the implant, but going the other way to being flat is, would not be a big procedure.
Okay.
Because the hardest part has already been done.
Right. And then we had one ask for clarification about the swimming question. The participant actually wanted to know, after a deep flap, if there's any contraindication to things like swimming.
No. After deep flap, the recovery time is can be pretty long, or can be at least a couple of months, because you have 2 scars to heal from, and having that abdominal scar on your abdomen from that tummy tuck really should not affect your ability to swim, especially since there is no muscle really, or minimal muscle that's removed from from harvesting that fat. And even if there's a tiny amount of muscle that is removed, and it doesn't really have much of a clinical impact, since it's so little. But otherwise, if they removed a lot of muscle, then they wouldn't call it deep flap. They would call it, the muscle-based flap, and that's kind of a different procedure, and that is commonly done these days.
Okay. I'm sorry, I said it was the last question, but it looks like we have a couple more. Are you okay with staying?
Of course.
Okay. So can you talk about what the pain management is like in the hospital after surgery?
Yeah, so it depends on the procedure, but in the hospital, usually patients will have had a mastectomy with or without reconstruction, and that's why they stay in the hospital overnight. And usually the pain medication that we give, some form of narcotics, you get every 4 to 6 hours, and you can get it can be like hydrocodone or codeine or something like that. You can get Tylenol. But you got to be careful with the hydrocodone. Sometimes it comes with Tylenol. So Norco has Tylenol in there. But you can also get ibuprofen, or some type of anti-inflammatory would be very helpful in kind of dealing with the pain. And gabapentin sometimes can be helpful too. Taken during the evening time, 300 milligrams, that may help kind of with the nerve ending, kind of the pains. After with tissue expander or implant placement, sometimes this muscle can feel really tight, and I find that just a low dose like muscle relaxant or some type of sedation like Ativan may help, just kind of relaxing that muscle. So those are kind of the main medications that we use.
Okay, thank you. And then this is the last question. So if you have radiation, is having flap reconstruction better than an implant?
It's a long debated question. I'm afraid I don't have the right answer for you, because it can be different depending on the plastic surgeon you talk to or the radiation doctors that treat you. You can get very different answers. I don't have a right answer. I can just tell you where I was before at the University of Chicago, where we did a lot of free flaps, a lot of deep flaps. We also did a lot of tissue expanders. We can tell you one surgeon preferred to radiate flaps only. He will not radiate tissue expanders. Another plastic surgeon's okay with either. And I can tell you at Stanford, they don't like radiating flaps. So you see here, like, even at very reputable academic centers, we're getting very different answers. So I don't think there's a right or wrong answer. Talk to your plastic surgeon about it.
Okay, great advice. And with that, I want to thank you again. And I want to thank all of you in the audience for participating. I think this was a wonderful, informative session. Hope you all have a lovely day.
Yes, thank you so much, Dr. Bao. And we hope everybody has a wonderful day. Thank you for joining us.
Thank you, everyone.